Our first symposium focuses on the crucial theme, bridging the golden hour and beyond, addressing timely interventions that save lives in acute medical care. I am pleased to welcome the chairpersons, Professor Namal Vijayasinghe and Dr. Arosha Abevikrama to the stage.
Good morning to you all. We'll start the first symposium. The title of the symposium is Bridging the Golden Hour and Beyond. Let me invite the first speaker, who is Dr. Channa Jayasekara. He's a consultant transplant hepatologist from Mayo Clinic, Phoenix, Arizona. He's going to talk to us on storms in the liver, navigating acute and chronic liver failure. Over to you, Channa.
Thank you so much, Mr. Chairperson. Thank you to SIMCON 2025 for inviting me to this very nice meeting, and it is a great honor for me to participate and come back to Sri Lanka, where I was born and raised. So thank you so much for your participation. The topic today is acute on chronic liver failure. This is a condition that has been recognized approximately in the last 15 years or so, and it is very critical that we identify these patients early on in their clinical course in order to hopefully reverse their clinical outcome in this high morbidity and mortality condition. The outline of my talk is to identify and define acute on chronic liver failure. I'm just going to refer to it as ACLF going forward. The clinical manifestations of this condition, assessing severity, and then the management interventions. I want to start off by clarifying some nomenclature. We use the words liver failure, I think, quite indiscriminately, and it is very poor nomenclature. Acute liver failure is, as we all understand, a very, very sudden decline in liver function in patients who typically do not have pre-existing liver disease. The common causes of this include paracetamol overdose, acute viral hepatitis, and certain medications. Chronic liver failure is a term I would really discourage the use of because it can refer to two different entities. Cirrhosis is the most common of those, and cirrhosis can be further stratified into compensated cirrhosis. These are the patients who don't have outward symptoms of liver disease, and then decompensated cirrhosis when you have outward symptoms of liver disease that include the development of encephalopathy, jaundice, ascites, variceal bleeding, liver cancer, and so on. Acute on chronic liver failure is the development of a sudden decline in liver function associated with some other organ manifestations, which could include brain failure, kidney failure, and so on, which I will go through in further detail. And it's important that we recognize the two distinct entities, decompensated cirrhosis and acute on chronic liver failure, because they have very different outcomes. When we talk about liver dysfunction in cirrhosis, we refer to liver insufficiency, which is typically manifested in coagulopathy, which is the prolongation of the PT-INR, the development of sarcopenia, or loss of muscle mass, jaundice, and then the portal hypertensive manifestations, which are typically what patients complain of: the development of encephalopathy, variceal bleeding, ascites, hepatorenal syndrome, and rarely hepatopulmonary syndrome and portopulmonary hypertension. These patients also have a vasodilatory state. They have a compensation from a cardiac function, so they have hyperdynamic cardiac function and low cardiac reserve. And then there's, of course, liver cancer. So if we were to look at the clinical course of patients with cirrhosis, you can see over time is a gradual decline, and this decline is manifested in decompensating events. But acute on chronic liver failure are patients who have some kind of pre-existing liver disease. They may have either compensated cirrhosis, or they may have some kind of risk factor like metabolic liver disease, fatty liver disease with fibrosis, or chronic alcohol use. And then they have a sudden decline that is unexpected. And this can go one of two ways. Either if you don't recognize it early, they will continue to progress and usually ends up in demise, or if you act early on, you may be able to salvage these patients to near normalcy or near baseline. In comparison, acute liver failure is a very sudden decline in liver function, usually requiring the consideration of liver transplantation to salvage the patient. Now, I don't want to delve too much into the definitions of acute on chronic liver failure. There's still some disagreement on exactly how to define this condition. The Europeans, Americans, and Asians have come up with 3 slightly different definitions. It largely hinges upon whether or not there is organ damage other than the liver in these patients. So the American and the European guidelines require some form of other organ dysfunction, may it be circulatory, respiratory, renal, immune system, or gut, whereas the Asian Association does not require that. And their rationale is basically to say that once those other organs start failing, the process has gone too far, and it is hard to salvage that patient. And if you put this in the definition, you will wait for this diagnostic criteria to be met, and then you may lose the patient. So let's not wait for those things to happen, act sooner rather than later. So in ACLF, you have liver insufficiency, portal hypertension manifesting in encephalopathy, variceal hemorrhage, vasodilatory state, but you typically don't have the more chronic problems with liver disease, and then you have organ dysfunction. So this is a practical definition that was put forward by the American College of Gastroenterology recently, is to state that ACLF is a distinct form of liver decompensation that is potentially reversible, and in patients who have some kind of chronic liver injury or cirrhosis. You don't have to have cirrhosis, but you have to have some form of liver injury. And there's usually an association with some multiple organ failure, and this happens acutely, and there's a high degree of mortality. The pathophysiology I will not go to in great detail because there's a very complex interplay of multiple systems going wrong. There's immune exhaustion in chronic liver disease. There's arterial vasodilation, bacterial and fungal translocation from the gut, adrenal insufficiency, and these patients are generally not very robust to overcome all of these things going on. There's a cytokine storm and so on. So the pathophysiology is very complex, and I will not delve too much into it. Suffice to say, as I alluded to already, the mortality of ACLF is what makes it so distinctive and so important to identify early on. So this is the probability of death at 28 days in patients who have ACLF. And on the x-axis, you can see the leukocyte count, which is an indirect marker of systemic inflammation. And you can see in this large study, this was one of the pivotal studies in ACLF conducted more than 10 years ago in Europe, and the mortality rate can reach 80 to 90%, whereas in patients with cirrhosis without ACLF, the mortality rate is much lower at this time point. The typical clinical presentation, now this is a type of patient that I will see very regularly in my clinical practice. 45-year-old man, works, functional, but consumes alcohol, approximately 500 milliliters for the case here, for several years, and develops jaundice, abdominal distension for 2 weeks, and now presents with hematemesis and hepatic encephalopathy. So if you were to assess this person's clinical status, there's encephalopathy, so there's brain dysfunction. We use the West Haven criteria in the US. I know here it may be the Glasgow scale. The circulatory system seems to be intact. The mean arterial pressure is okay at 65. Vasopressors are not required. Respiratory function is good with oxygen saturation of 95%. The bilirubin is markedly elevated. Creatinine is elevated. Immunologic failure is suspected based on elevated white cell count, and of course the patient is acutely anemic with a hemoglobin of 6.5 and ascites is present. We use the MELD score very commonly in the United States for this type of patient. The MELD score is actually not a very good scoring system, and I will talk to the scoring systems in a little while. Is anyone familiar with the MELD score? Is that something that is used here? Yeah, okay. So a MELD score of 37 is actually a very high MELD score. The range is 6 to 40, and the MELD of 40 is a very bad prognostic indicator. In terms of the aspects that suggest ACLF in this patient, the clinical symptoms are acute. There's an underlying chronic liver disease from alcohol use. This patient may or may not have cirrhosis. We don't know at this point. There is some precipitant, which was the development of acute alcoholic hepatitis in this patient. He complained of jaundice and ascites in the past 2 weeks, which are pathognomonic features of alcoholic hepatitis. And then there's an acute insult. So the gastrointestinal hemorrhage is the acute insult, and this patient now has organ failure manifesting in liver failure, brain failure, and renal failure. In terms of management, the typical management we would do for this patient include intubation for airway protection in someone who's throwing up blood. We would sedate the patient using dexmedetomidine rather than benzodiazepine because benzodiazepines are not metabolized very well in the liver. Ceftriaxone is a critical intervention to prevent spontaneous bacterial peritonitis. Transfusion of blood to a goal hemoglobin of 7 grams per deciliter, gastric acid suppression with PPI, and the use of a somatostatin analog such as octreotide to reduce portal pressure. This is all standard of care. Patient will be admitted to the ICU. The upper endoscopy will be performed emergently, usually the same day. And the assessment of varices is performed, banding is performed. Lactulose is started to treat hepatic encephalopathy. And invariably, these patients will get a paracentesis. It is essential that patients get a paracentesis regardless of abdominal symptoms to rule out spontaneous bacterial peritonitis. With these interventions, the patient has turned around on hospital day 6. You can see the West Haven classification has improved from 3 to 1. The bilirubin has improved, INR has improved, creatinine has improved, mean arterial pressure remains stable, and respiratory function remains stable. MELD score has improved. And you can see that this clinical case is very different from our typical patient with decompensated cirrhosis, where there's a much more gradual emergence of those problems, ascites, encephalopathy, varices, and their complications occur much slower in decompensated cirrhosis compared to ACLF. So in terms of precipitants, 40 to 50% of patients with ACLF do not have an identifiable trigger. It's kind of pointless to really go digging in and trying to figure out what's happened. You have to take care of the patient in front of you emergently, regardless of what it is. And of course, you want to do a basic workup to find treatable causes, such as viral infections, drug-induced liver injury, autoimmune hepatitis, and so on. But in general, there's a large proportion of patients who don't have an identified trigger. In this patient, it was alcohol and the bleeding episode. And then here are the scoring systems. So we typically don't use the MELD score. The MELD score can be used as a rule of thumb, but the international groups studying ACLF have come up with somewhat better scores with higher sensitivity and specificity in identifying, diagnosing, and risk stratifying ACLF. The CLIF-C score is one of the ones that we use very regularly. It is used to diagnose ACLF, and each organ system is assessed individually, and you can use an online calculator. I'll show you the calculator that I use. It's on my phone, and you just punch in some numbers, and you get a classification of the ACLF grade. So there's 3 grades, grade 1, 2, and 3. Grade 1 is basically the development of ACLF with either just kidney failure or some other organ system and maybe some mild kidney failure. That's basically the grade 1. The 3-month mortality is about 22%. Grade 2 is when 2 organ systems are down, higher mortality rate. Grade 3 is when 3 or more organ systems are down with a much higher mortality rate. This is the app that I use. I have no financial interest in this, but it's called HepCalc, and it has many different liver scores that can be used, including MELD, Child-Pugh, and so on. Also the alcoholic hepatitis scores. And these scores are important. I think we should be using these scores very routinely in all of our liver disease patients because they're developed for a reason. So here's the presentation scoring system for this patient. He had grade 3 ACLF with more than 3 systems down. His CLIF score was 60, and you see the numbers there indicating the mortality rate. And at day 6, you see that the ACLF grade has improved to 1, and the mortality rate the predicted mortality is lower. So the point that I'm trying to make here is that ACLF, despite how dire the situation of that patient was, can be reversed if you intervene quickly. And the CLIF score is important because it helps us identify and risk stratify these patients. It helps us identify what kind of treatment decisions should be incorporated and how quickly. It helps us identify where this patient should be. Should the patient be in the ICU? Should the patient be on a ward? And it helps us monitor the disease progression, and you can calculate the score with time and then determine how the patient is doing. And importantly, it's important to tell the patient's family, here is the current situation of this loved one of yours, and here's what we are going to do, and this is the risk that we're dealing with, just to set their expectations, because this is a very serious situation. So in summary, the management principles for these patients: if there's encephalopathy, you want to protect the airway. That's very important. Lactulose is the mainstay of that. You want to rule out competing causes of encephalopathy. We don't use ammonia levels. Is ammonia used here for management of encephalopathy at all? I see no hands. Okay, that's excellent. Infection is very common in chronic liver disease. You have to assess these patients for SBP in particular. Anyone with ascites should have a diagnostic paracentesis and rule out of SBP, regardless of their symptoms or absence of symptoms. And empiric antibiotics are very reasonable in patients with cirrhosis. It's one of those things that we say in the US, you shoot first and ask questions later. Of course, there's a big gun culture in the US, as you know, so that's where that comes from. So circulatory support is very important. The mean arterial pressure is a very strongly, independently validated marker of outcomes in ACLF. You want to have the mean arterial pressure greater than 65 in these patients, and you want to have a very low threshold to start them on vasopressor therapy. For airway protection, we talked about intubation already, and avoidance of benzodiazepines. We typically do not paralyze. And then for coagulation monitoring, the PT-INR is not a very good marker of coagulopathy in liver disease. We typically use the thromboelastogram, but that is a costly test. So in the absence of that, an INR is reasonable. And nutrition is important. If there is no risk of aspiration, this patient should be started on some kind of enteral feeding right away. I want to talk a little bit about renal dysfunction in cirrhosis. And this includes both ACLF and decompensated cirrhosis, because this is a very important aspect of cirrhosis management. About 53% of hospitalized patients in the US at least have some degree of renal insufficiency, and it is a very strong, poor prognostic factor in liver disease. The MELD score in particular was created to incorporate creatinine. As you all may remember, previous to the MELD score, there was something called the Child-Pugh score, which has fallen out of favor because it did not actually incorporate kidney function. When kidney function deteriorates in liver disease, that is a bad sign. And so these patients have to be managed very assiduously if they do develop renal dysfunction. The etiology is just like in other causes of renal dysfunction: pre-renal acute tubular necrosis and contrast-induced nephropathy are important to assess. But the one that you really want to assess for is hepatorenal syndrome. So hepatorenal syndrome is now called HRS-AKI because it is a continuum of renal dysfunction that includes acute kidney injury and hepatorenal physiology. And we typically do not use the type 1, type 2 nomenclature that was there for many years. So it's now just HRS-AKI. There's a diagnostic criteria for that. And the incidence is about 18% in patients who have cirrhosis and ascites. The highest risk is in patients who have cirrhosis and hyponatremia. And as you know, the MELD score now, there's been several variations of the MELD score. There's the basic MELD, then there's the MELD sodium, which includes the sodium because of how important hyponatremia is in cirrhosis. And then the newest MELD score also includes albumin. But suffice to say, in patients who have hyponatremia and cirrhosis and ascites, these patients are at very, very high risk of hepatorenal syndrome, and it carries a poor prognosis. The definitive management of hepatorenal syndrome is liver transplantation, which is obviously not an easy thing to do for most patients. And then there are temporizing measures like the timely use of splanchnic vasoconstrictors, volume expansion, dialysis tips, and so on. In terms of the management principles, you want to make an accurate diagnosis. You want to rule out other causes of renal dysfunction, which are very common. You want to stop diuretics at that point, because diuretics will progress hepatorenal syndrome. And you want to stop vasodilators because you want to make sure that the kidneys are perfused. So if they're on a beta blocker like propranolol or carvedilol, you want to stop those at that time point and ensure that the kidneys are perfused adequately. You want to measure their urine output. A drop in urine output is a bad sign. And you want to replace their intravascular volume to treat any kind of pre-renal azotemia. And we typically use albumin. If albumin is costly or difficult to obtain, you may use a crystalloid like saline. If there is no response, we have now in the US at least shifted to terlipressin. Terlipressin has been available in Europe for many, many years. It was hung up in the FDA and the US for many years. Finally, we got approval about a year ago. Is terlipressin available in Sri Lanka? Yes, okay, perfect. You are fortunate. So you have the access to that drug, which is really quite remarkable. The response rate to terlipressin is about 44% in the clinical trials. And it should be used preferentially. If it's not available, norepinephrine is a good alternative. And then you want to target a mean arterial pressure improvement of greater than 10 millimeters mercury. Midodrine used to be the drug that we used to use. It's not that effective. And then, of course, you want to consider renal replacement therapy in these patients. Liver transplantation, of course, in selected individuals. I will not go over this very complex chart, but there's a very clear-cut algorithm for diagnosis of renal insufficiency in cirrhosis. Finally, I just want to touch on fluid resuscitation in cirrhosis. As we know, patients with cirrhosis have splanchnic vasodilation. They have circulatory dysfunction as a result, and these patients are frequently total body volume overloaded with intravascular volume depletion. When patients come in with worsening renal failure, and if they are, say, bleeding, for instance, you want to replace them replace their fluid volume in a thoughtful way. Crystalloid and colloid is the classic debate that is always had. Crystalloids, you need larger volumes. They can third space very quickly into the peritoneal cavity or the chest cavity. Lactated ringers and plasmolite, which are called balanced solutions, can worsen alkalosis. Colloids, on the other hand, theoretically don't have those risks. They stay in the vascular system longer, but they have not been shown to significantly improve short or long-term outcomes. A very pivotal study in the New England Journal of Medicine a few years ago. In situations of shock, crystalloids are perfectly reasonable, so you can use normal saline in these patients as a resuscitative fluid. In summary, ACLF is a very acute and high mortality condition, which is distinct from decompensated cirrhosis. It's very important to identify this condition early. And most patients will require ICU, and with timely interventions, you can salvage these patients, and it's very important that we work diligently to address this condition. Thank you so much.
Thank you, Dr. Jayasekara, for the informative lecture. May I call upon Dr. Upul Wickramaratchi, Consultant Interventional Cardiologist, Lanka Hospitals, Colombo, to talk on evolving landscape of ACS management.
Right, good morning, everyone. Thanks for the introduction, and it's a privilege to be here. So thanks very much for the invitation for the organizing committee. Right, I've listened to only 2 talks, and I'm thinking, honestly how tough your job is. And thank God I chose cardiology, and I don't have to know everything about every system, just as a note. So hats off to you guys. So my talk is on the evolving landscape of ACS management. This is not about the whole ACS management spectrum, but just a few changes that are happening. And the overview is, so I'll focus on rapid diagnosis and risk stratification, antiplatelet and antithrombotic therapy, revascularization strategies, and also on secondary prevention. So rapid diagnosis, the key is key in ACS management, as we all know. So the gold standard is ECG under 10 minutes for all patients presenting with chest pain. And also recognizing STEMI and STEMI equivalent is important. As we all know, the term occlusive MI is now increasingly being used instead of STEMI, and I think it'll probably be the most commonly used nomenclature in the future. Increasingly, AI assistance is used to increase the accuracy of diagnosis, but at the end of the day, we should not forget the patient in front of us, clutching his chest with chest pain, and we can look at the investigations later on. So ECG, very important. High sensitivity troponin really changed our approach. Point of care troponin that would give us an instantaneous result by the bedside is important, so we can rule in pretty quickly. Of course, ruling out would need more troponins, at 1, 2, or 3 hours, depending on the assays you have in your hospital. Accelerated diagnosis pathways you can have in your hospitals that would keep your junior colleagues comfortable, and also use of point of care ultrasound. So ECG, your troponin, and if you have ultrasound, point of care ultrasound, where you can, if you have colleagues who at the front door who can do an echocardiogram and recognize regional wall motion abnormality or features of alternative diagnosis such as pulmonary embolism, aortic dissection, myopericardite, I think it'd be it'd be great for the patient. And I know your college is doing a great amount of work in that, and congratulations on that. So risk stratification tools, I'm going to go back to these later on. So we use CRAE scores, TIMI scores, heart score. How much of this we use in our day-to-day practice is questionable, but at least they're there to guide us when we need them. So that's about diagnosis. So I think the key for us is probably more usage of point of care troponin and point of care ultrasound to improve our practice in Sri Lanka. The evolution of antiplatelet therapy is one area we're really lagging behind because in the developed world, at least where the resources are there, as the clopidogrel has been replaced with ticagrelor and prasugrel. That's because of the improved outcome data. Ticagrelor showed improved cardiac death and less ischemic events. Prasugrel showed less ischemic events compared to clopidogrel. So prasugrel is still preferred in the STEMI setting, ticagrelor in pretty much all settings. There is some increased non-cabbage bleeding risk, but when you look at the overall benefits versus risks, the benefits would outweigh the risks. So that's one area we can really, and I think with time, the price would come down, and we'll be able to use these agents to most of our patients. It's important to know about de-escalation strategies as well, because there will be patients who develop bleeding and other complications who are needing urgent surgery after intervention. And I think it's important to be in touch with your interventional colleague who did the procedure, who have an insight into what their coronaries look like and what the actual procedure was like before we do that. But most novel generation stents are okay to have just 1 month of depth and de-escalate later on. But I think that dialogue is important for the benefit of our patients. Anticoagulation upgrade, this is another area where we can do better. We still use enoxaparin as the box standard therapy, but rest of the world has moved on. Fundoparinox has shown better clinical outcomes, less mortality at 6 months. That's purely because of less bleeding. So it's easy to give once a day dose, 2.5 milligrams subcut, than our usual enoxaparin 1 milligram per kg BD dosing. Unfractionated heparin remains the standard in PCI. We can use bivalirudin if we need, and also NOACs is used in a combination with antiplatelets if ASIS patients have got atrial fibrillation. Right, revascularization strategies. So as we all know, primary PCI is the gold standard for STEMI patients. Preloading can be done with single antiplatelet or dual antiplatelet. If you're thinking of ticagrelor or prasugrel, usually loaded on the table, but if it's clopidogrel, you can load in pre-PCI setting. And I'd like to draw your attention to giving IV heparin before transferring to a PPCI center, because this has shown to increase the infarct-related artery patency and also to reduce mortality. So that's something that I do regularly now where I practice. So in the ETU itself, if I diagnose a STEMI, I would give the IV heparin either 4,000 or 6,000, depending on the body weight, before I take them to the cath lab. And actually, it has made a significant, palpable difference anecdotally as well in my experience, where sometimes the patient is pain-free by the time they're on the table, their STs have settled down, the artery is open. And especially with patients with multivessel disease, this will open the door to have, bypass or other treatment options rather than having multiple stents in multiple places. There's a trial that was published 2 weeks ago, SLCIM, that's a GP2B3 inhibitor subcut, once stat dose pre-hospital, increasing the infarct-related artery patency, and quite promising results. This may change the STEMI landscape in terms of preloading, because remember, preloading with ticagrelor and clopidogrel didn't really make much of a difference in the trials in the past. So that's something to look out for, SLCIM, that's a GP2B3 inhibitor. We all know radial access reduces bleeding and improve mortality. Intracoronary imaging and physiology. So this is another area where we can do better. So intracoronary imaging there are two modalities. IVUS is intravascular ultrasound, OCT is optical coherence tomography. IVUS is cheaper than OCT. It's just a kind of example. IVUS has been there the rest of the world for over 20 years, and we are still struggling to get it up and running in our country. So where we put a tiny catheter with ultrasound probes inside the coronary artery, where we can measure the diameter, the length of disease. If you put a stent, we can see how optimized the stent is, so giving ultimate benefit to the patient with improved clinical outcomes. Fractional flow reserve is the same, so FFR, where especially related to the non-IRA, non-infarct-related artery. So if you have a moderate to severe lesion, or let's say moderate lesion, whether to do PCI or not can be questionable sometimes in those arteries, where we put a wire with a pressure sensor down the artery, and we look at the pressure difference before and after the narrowing, and we get a real real idea about the physiological importance of this stenosis before committing for treatment. So these are two areas where we really can do better, increasing the uptake for at least IVUS, which is as good as OCT in terms of clinical outcomes in the studies, and also FFR or IFR to guide us physiologically. Then comes the question, especially in the STEMI setting, when we have multivessel disease, do we treat just the infarct-related artery, or do we treat all the other lesions? The evidence suggests complete revascularization is better. When to do is a very patient-dependent factor. Most STEMI patients have got irritable myocardium, and they're unstable, they're in agony. So it's only natural for us to fix the one that's causing the problem and take them off the table, let them settle down. The evidence suggests, so we can do the other lesions, we can do PCI to the other lesions in the same hospital admission, let's say after 40 or 72 hours if the patient settles down. If not, under 45 days, that's where the evidence is as a stage procedure. So complete revascularization is the way forward. And CABG, of course, can be considered if they've got multivessel disease, especially including left main stem. Timing of angiography in non-STEMI. This is another area where things have really moved on, and we are struggling for obvious reasons in this country, but we should aspire to do better in these areas as well. So STEMI, as we know, we try to do revascularization under 2 hours, and in non-STEMI, there are now 3 categories: the very high risk, and the non-so high risk. So the very high risk category, I don't know whether you can see the ESC chart. So if they've got hemodynamic instability, cardiogenic shock, early heart failure, malignant arrhythmias, mechanical complications, we treat them just like our primary PCI patient and try and get the revascularization done under 2 hours. And if they're high risk, that's confirmed non-STEMI or gray score more than 140, again, dynamic ECG changes, and any of these features, we try to get them the angiography done under 24 hours. And others, we can decide based on their clinical suitability, their frailty, their mobility, their renal functions, their anemia, and all of that. So other countries, for example, I can say in the UK, we started developing rapid non-STEMI pathways, good 6-7 years, where we, like the primary PCI, we bring the non-STEMI patients straight from the community through an ambulance straight to the cath lab. And actually, these are, real diagnosis where the EC changes their pains, typical classic ischemia, not the ones that, that borderline diagnosis. It not only makes a difference to the patient outcomes, but also it saves bed days, because most of these patients were discharged following day, just coming up to 48 hours. So it has an impact on both sides. So this is an area we can do better in improving access to angiography for these non-STEMI patients as well. Now, device strategy. Guidelines suggest drug-eluting stents, and the trend is to implant newer, thinner strut, bioabsorbable polymer stents. So basically leaving the least amount of footprint as we can. Now, some of you may know my special interest lies with drug-coated balloons. That's stentless PCI, where we treat with a balloon with a drug around it and treat them without putting a permanent implant. And I think this technology is quite pertinent to our part of the world, where we have smaller coronaries, we have more diabetes, and we have more diffuse disease, and our patient cohort is much younger than the Western populations. So it has more place here. And actually, if you look at Japan, 25% of PCI is done with DCB at the moment. Malaysia nearing up to 30-40%. And I'm pleased to say in Sri Lanka also, it's now being taken up gradually, so it's nice to see that. And it has got other advantages, which I'm not going to delve into under this topic. So, secondary prevention. Now, we've got the patient through the doors, we've given them the appropriate treatment, and then is the beginning of the next part of the journey, where we would try to reduce the recurrent events for this patient. That's where the secondary prevention comes, and it is very, very important, as we all know. So high-intensity statins, there's nothing new about it. For all ACS patients, we would try an LDL of less than 55, a goal of LDL less than 55. But there are newer agents in our armamentarium now. So in addition to ezetimibe, we have the bempedoic acid, inclisiran, PCSK9, and I'm sure these agents will be. Bempedoic acid, we can get it in Sri Lanka, and inclisiran and PCSK9, I'm sure will be available in the near future. So we can get optimal lipid therapy for these patients. Diabetes mellitus and heart failure considerations. I think as a nation, I don't have the data, but I think we are pretty good in our SGLT2 inhibitor treatment initiation for these patients. GLP-1 agonist will be hopefully available soon, and ANI. Now I want to speak a word about ANI and I would like to encourage all the physicians to start using ANI for patients with symptomatic heart failure with EF of less than 40% as primary treatment. It is a wonder drug, and I think it is one of the greatest inventions in the recent past. Both scientifically and anecdotally, I can tell you there are patients with EF of 20-25 walking with no diuretics, and if you see them, you'd never tell them their EF is 25. So it makes a remarkable difference, not just for LV function, but their clinical improvement for these patients. So I would really encourage whenever, and the prices have come down with more products being available, prices have come down, so ANI will play a key role in keeping these patients at home. Right, next topic, targeting residual inflammation. This is really big, and I cannot really emphasize the importance of this as I put in for the Arnie. Light bulb moment for me was the meta-analysis published for all the colchicine trials back in late 2021, which when it showed less mortality and less MI and less stroke risk when colchicine was used post-MI. I started back then in 2022, then came the FDA approval in 2023, then it went to the ESC guidelines in 2023, which gives us real boost to our confidence to use colchicine in post-MI patients. So the evidence suggests that actually targeting residual inflammation will reduce your future event risk more than achieving the LDL goal. So it's that important, and I cannot emphasize this. So in the trials, people were given colchicine post-MI, irrespective of their inflammatory status. It can be given now if I have a patient, with no renal failure, young patients with a lot of diffuse disease. I fix the most critical, but there are other lesions that are, with diffuse disease. I may start them straight away on colchicine before discharge. In other patients, all the other patients, what I do is I check their CRP and high sensitivity CRP at 1 month's follow-up. As we know, statins are potent anti-inflammatory, statins, SGLT2 inhibitors, all of them. So if their CRP is normal at 1 month, and if their high sensitive CRP is more than 3, I would put them on colchicine if there's no contraindication. That's 0.5 milligrams once a day. And I think it's quite important to our part of the world because we manage our ACS still mostly medically, and that would help to bring their recurrent event rates down. And if it's more than 2, I would consider starting. If it's less than 2, I would give a little bit of time, see whether it comes down. This is high sensitivity CRP, not CRP. 2 things to look out for gastrointestinal side effects. Not very common in Sri Lanka from my experience. But one thing to look out for is neutropenia. So my patients who are on colchicine, I would check at least for the first year or 2 their full blood count at every 3 months or so to make sure they're not going neutropenic. And there are novel therapies being developed, the monoclonal antibodies, and they're coming. And I won't be surprised if in the future, if we give an infusion of these at the ETU, together with some PCSK9 infusion before we give them other loading therapy and all that. That's where it is heading. So cardiac rehabilitation, it's underutilized. As we know, it's multidisciplinary. There isn't really anything new on this, but I just put this slide to highlight the importance of it. And what I do if the patients we think are not going to attend a hospital rehab follow-up, actually British Heart Foundation website has got some really nice videos where people can go through from home, from introduction to staged exercise regime, and that's what I forward give my patients. So very important cardiac rehabilitation. Digital health and telemedicine. This is where we can actually triumph, I think, because it does not need much infrastructure. We have the brains. We just need a bit more collaboration with our engineering colleagues and other colleagues to come up with systems where patients can be monitored remotely, medication adherence, cardiac rehab, and other risk prediction tools. So there's a lot to do. And this is a huge area where we can also really contribute massively, I think. Diet and exercise. I thought I'd put this slide because there are various sects where are various dietary patterns described online these days, but my recommendation, let's focus on the good fats. I don't think there's any debate on good fats, which are the PUFAs and the MUFAs. We have our lovely avocados here, we have the peanuts, we have the fish. So if I tell you the fish with highest amount of omega-3 in Sri Lanka is kumbalao, I think you'll be a bit surprised. So my recommendation is loads of kumbalao, linno, hurullo, karallo. Those are the 4 types of fish with highest amount of omega-3 in Sri Lanka. Not expensive. I'm promoting to all my patients. So if the kumbalao price goes up, it's not my fault, I'm sorry. And also less carbs. We eat too much carbs, as you know. Sometimes I see in the hospital, when the big batmula is spread out. Sometimes when I walk past, I ask them, look, can I join too? Because it's really enough for 3 people. So I think cutting down on the carbs is important for us as a nation. Then, of course, having more fiber, fruits, vegetables, including nuts and nuts also. And exercise, let's keep moving, let's take the stairs instead of the lifts, let's walk as much as we can, and let's tackle central obesity, as it was mentioned in the oration last night. I cannot emphasize the importance of tackling central obesity rather than waiting until your BMI is higher, because we are lean, but we are obese. We have visceral fat. Right, so future directions would be, so I've talked about early diagnosis, ECG, point-of-care troponin, use of point-of-care ultrasound if possible. I've talked about antiplatelet, where we have to shift to ticagrelor and prasugrel as soon as we can. I've talked about timing of the treatment strategies, so giving early angiography and making it available for patients as soon as possible. Devices, anticoagulation therapy, targeting anti-inflammation, and a bit about diet, exercise. So the future directions would be personalized antithrombotic, anti-inflammatory, lipid-lowering medications. Regenerative medications, especially for heart failure patients, would be are coming. Expanded role of intravascular imaging and physiology, as I was mentioning, and then integration of AI into clinical workflows. Wearable devices giving us real-time monitoring, as well as physical monitoring, as well as biochemical monitoring. I think those would be the future directions. So diagnosis faster and more accurate, therapy is more personalized, revascularization is increasingly imaging and physiology guided. Secondary prevention is essential for better long-term outcomes. I'd like to end my talk with that. Thank you very much. Thank you. Thank you.
Thank you, Bull. Excellent talk. So, the final speaker does not need any introduction to this audience. This is Dr. Ganaka Senaratne, consultant physician. He is head of the Department of Emergency Treatment Unit, Teaching Hospital, Karapitiya. Over to you, Ganaka. Ganaka is going to talk to us on From Subtle Signs to Saving Lives, a physician's guide to early detection.
Thank you, Chairperson, for that kind words of introduction. Good morning, ladies and gentlemen, President Krishantha and the Council of SLCIM. Thank you very much for giving this opportunity to me. So let's begin with a moment from the boxing ring. This is the famous fight happened between Muhammad Ali, champion of compassion, and Collie Wallace. In the mid-fight, Ali stopped throwing punches all of a sudden. He had noticed something very subtle, a sign that something wasn't right in Collie's face and eyes. Ali insisted the fight to be stopped and Collie to be taken to the hospital. So they did, and he got treated for his intracranial injuries on time. So this is not a story on sports. This is perhaps a reminder for all of us in clinical medicine, how important the detecting subtle signs and how we could save patients' life. In fact, early detection of critical illness is a wonderful and very powerful tool that we have. With that note, let's begin From Subtle Signs to Saving Lives, a physician's guide to early detection of critical illness. This is the outline. Right, who are critical ill patients? There are two broad categories. The bigger category is patients with deranged physiology, and there's another category with time-critical illness. I will explain them in a minute. Patients with deranged physiology, as we all know, physiology keeps us alive, isn't it? When the physiology stops, we call it death. Permanent cessation of brain function is the definition of death. So deranged physiology drives us towards cardiorespiratory arrest and death. It's because of the same reason, not because of the pathology which has caused the deranged physiology. So it's a very rapid process, as you can see in a highway. And we travel very fast. You can't take back also. So deranged physiology drives you through hypoperfusion, through multi-organ failure, and through cardiorespiratory arrest to death, very rapid. We call this golden hour. Unless, well, you can't turn back, but if you know the exit, you can take it. If you identify the patient at the level of hypoperfusion, you make the perfusion better, take the patient out from the exit. So as all these exits can be tried before the patient reach death. Right, this is drowning, isn't it? What do you feel when you see somebody drowns? Do you get an alarm in your heart? Yes, we do. My goodness, this patient is dying. So do you fix an aim in your brain? Yes, you want to save this patient. You do something and you shout and you do whatever you can. So the deranged physiology is actually state of drowning. You don't see the water, but they are sinking. So how to save this patient with deranged physiology is to, first of all, develop an alarm in your heart to say that they are dying, and build up an aim in your brain that you want to save them. Shout for help and do something that is to stabilize the physiology so that you prevent the further progression to cardiorespiratory arrest, and then address the pathology which was the cause for this deranged physiology. Coming to the patients with time-critical illness, well, they have a sort of a normal physiology, which is certainly not deranged. But I think this pathology they have might affect their physiology in very quick time. It's like you are taking the ticket to enter the highway. In a minute, you are traveling in the highway towards cardiorespiratory arrest and death. Right, how to save those people is to detect that critical pathology soon enough before it affects the physiology, so then you can start treatment. Right, coming to the detection of those broad categories of critical ill patients, the patients with deranged physiology, actually we need to identify these derangements early enough. The vital parameters is therefore measure the physiology. So you need to measure vital parameters. That's why the news is, I know the college has been doing a lot on bringing up the standards on news, saving many lives in our land. Coming to the patient with time-critical illness, there are a few ways that you could detect them. Through the history, through the general inspection, physical signs, mental state changes. You could use POCUS, some investigation abnormalities, trends, and of course, clinical reasoning and judgment would become really, really handy in this state. Right, I will try to explain these things by some patient stories, one by one. Using the history to detect critical illness, Mr. Piyadasa, a COPD patient on inhalers, admitted with fever 3 days ago and cough. He described an episode of very brief episode of loss of consciousness today, denies any chest pain or headache. His saturation was 88, respiratory rate was high a bit, had few bilateral bronchi. He brought the ECG with him, which shows sinus tachycardia. Now I want all of you to join with these questions. You can scan this QR code and share your opinions on this. Can we all scan this QR code, please? Right, here's the question. Are you worried about Mr. Piyadasa? Yes or no? Right. The majority believes, majority worried about Piyadasa. I think that's the... so we were also worried about him. So this is the dialogue to follow. So we wanted to take more history. So this is the dialogue to follow. What were you doing at the time of the collapse? I was walking. Where were you going? I was going home from the hospital. What did you go to the hospital? I have been in the local hospital for 3 days for same issue. Was discharged today with painkillers for my leg pain. So that was his history. Right, coming to the second question. The question is missing, okay. What is the diagnosis that you want to make here? Is it a COPD exacerbation? Is it neurological syncope, or is it something else? Pulmonary embolism? Yes, it is. So this was the focus of his heart, showing RA-RV dilatation and hyperkinetic right ventricular apex, and the CTPA shows the thrombus in the right main pulmonary artery. So submassive PE has been diagnosed, and he was thrombolized because of hypoxia later on. And worrying that something is wrong and getting the history of hospital stay was the key to detect this pulmonary embolism, and which saved him, I believe. If not for this, we would have diagnosed COPD exacerbation or syncope or something. Pattern recognition was really helpful. Immobilization, syncope, hypoxia with minimal lung signs, you need to suspect PE, isn't it? The essence is, ladies and gentlemen, that ability to dig relevant history can save lives. And pattern recognition also do the same. Well, the history is not something patients say. History is something we think and dig. There are so many gems in the history that we need to be mindful to dig the correct place to find the gems. You need to think and do that. And ask questions from the patient to visualize the anatomy, pathology, complications, etiology of the illness, and the temporal nature. All are very important, so that you get some word into your brain, you analyze, and you come up with some critical thinking. And developing the sense of worrying is also very, very important. Right, coming to the second story, using general inspection. Mr. Supun, 25-year-old gentleman from Galle, admitted with fever and feeling unwell for 3 days. Cough, he has been having cough and whitish sputum for 2 weeks. His vitals were stable, no lung signs, nothing much. When we pull his sleeves up, this is what we saw. And then we asked further history, and he very reluctantly said that his father is an inmate in the prison, and he has gone and visited him recently. Coming to the third question, what is the diagnosis? Is it chicken pox? Is it meningococcal sepsis? Very easy question, no? Right, it's nothing else, is meningococcal sepsis. So this is a gram-negative cocci in his blood culture. And meningococcal sepsis has been diagnosed, so we were ready for upcoming disaster. All the management steps have been done. He has to be sent to HDU for further care. Catching the rash and history of visit to prison was the key to save this patient, I believe. If not, we would have made a diagnosis of respiratory tract infection. The essence is, general inspection can detect critical illness and save lives, that we need to know. First 30 seconds at bedside often reveal key clues. You need to look appearance, posture, interaction, clothes, how they talk, their face, like Muhammad Ali did. And rapid global assessment before focusing on vital is such an important thing. And you need to try and connect what you see with all the anatomy, pathology, complications, and etiology, so that you could Connect the sign with your thinking process. Coming to the third story, using the subtle physical signs to detect critical illness. Mr. Pereira, 50 years old gentleman with diabetes, admitted burning chest pain for 2 days after eating kottu. When asked about shortness of breath, he said he had mild shortness of breath on exertion. Vital parameters stable, lungs clear. He had epigastric tenderness. And he came with an ECG. And this is his auscultation. Can we play this video? Can you hear this? Right, the question is, what can you hear? Is it S3 gallop or is it loud S1? Well, majority believes it's S3 gallop. I think it is. And this was his focus of lungs showing bilateral B lines and the heart showing poor EF. Right, LVF and APO has been diagnosed, confirmed, and he was started on correct treatment. Soon he has to be put on CPAP because he deteriorated quite quickly. And he was recovered with all the HDU and CCU care. So I think picking up this subtle S3 gallop was the key to save this patient. If not, you diagnose him as GORD. So subtle signs often appear hours before collapse. We need to know that diabetic patients can have atypical presentations also. And if you take the positive predictive value of clinical signs, there are some signs showing very high positive predictive value. For instance, S3 has 70 to 90% of positive predictive value. So you need to make use of this data and be sure about your pathology that you are seeing. So the essence is ability to detect physical signs can save lives. But actively searching for physical signs is the best practice. It's not something you examine top to bottom. You need to think what you need to see and then examine this patient. Through physical science, we need to visualize anatomy, pathology, and complications. Focus can help, but apply clinical reasoning before using the technology. That's something we need to do. Coming to the fourth story, using mental state change. 40 years old Mr. Pradeep, on treatment for diabetes and depression, was admitted with chest pain, and he has been diagnosed as acute STEMI. And he was thrombolyzed and has been worrying a lot from the admission about his illness. All of a sudden, he became aggressive. So what do you think the cause of aggression? What is the possible diagnosis? It is, sorry. What is the, that question is missing, I'm still sorry. So this was so we thought he has a very complicated pathology, and so we straight away taken into to the monitors and attached the monitor. This is what we saw. The question is, yeah, that was a VT, so question is not appearing, very sorry about it. So it was diagnosed as VT and medical emergency alarm has been sent off and quickly sedated. He had to be given staggered shocks and he recovered. So trusting clinical intuition, something is not right, saved him. And if ignored, we would have found him at the level of cardiac arrest. So he was given quick, compassionate care. A sense is considering rapid mental state changes as a manifestation of serious complication, save this patient. New confusion, agitation, interaction of subtle drowsiness, or not being themselves, we need to consider very, very seriously. Before we putting them down to functional status, always we need to think whether there's a connection with the pathology, or at least whether there's any iatrogenic cause for those manifestations. Coming to the last story, 75 years old Mr. Premadasa with pharyngeal carcinoma on radiotherapy was brought in with multiple complaints: abdominal pain, fever 1 day, productive cough, urinary symptoms for 2 days, back pain for few days. He was a bit hypoxic, tachypnic. He had bilateral crepes in lungs, and abdomen was mildly tender and mild guarding was there. Focus of lung shows B lines, normal EF, fast scan normal. He had a lactate of 15. Question is, what is that was a wrong question, no? So he was diagnosed as acute abdomen with ARDS. So surgical review, we suspected because of this high lactate, he should have something in his tummy. So surgical review was done and acute abdomen was diagnosed. So actually he had a ruptured peptic ulcer. Finding guarding and very high lactate was the key to save this patient. If not, we would have easily diagnosed lower respiratory tract infection or UTI. So high lactate always needs exclusion of bowel pathology, and clinical judgment and reasoning is very, very important. So essence is interpreting investigations in relation to history and examination can save lives. We need to organize investigations to visualize anatomy, pathology, complications, and etiology. The other side of the coin is that we should not expect answers to all our questions from investigations. We need to have something called clinical judgment and reasoning that saves most critical ill patients. Critical illness patients are often multisystemic actually. They have problems in their CVS, respiratory system, neurology, many symptoms and signs, many complications. So we need to use pattern recognition, likelihood ratios, natural history, experience, evidence, knowledge to analyze those. So you perceive those and you analyze with these elements and come up with a diagnosis. And you need to detect and prioritize the condition which needs to be treated first. That's really, really important in emergency. So this is the physician's guide, ladies and gentlemen. Ask yourself why. Do not satisfy your brain until you have answers for all your whys, like Sherlock Holmes. Search for signs and symptoms, not something they tell, but you need to search for those. You need to make a 3D mind map of anatomy, pathology, complications, etiology, and temporal nature. That is what you call diagnosis. Diagnosis is a process. It's not a word, but it has a lot into it. You need to have all the elements in the diagnosis, like I mentioned here, otherwise it's not a complete diagnosis. Trust clinical intuition, something is not right. Do something to detect the dangerous pathology. Subtle signs often appear hours before deterioration. Take home message, deranged physiology kills soon. Time critical illness will derange the physiology soon. So we need to develop an alarm and aim in our heart and brain to save them. Subtle signs save lives, as I showed you. So use physician's guide. And with all those facets, bring compassion, like an empathy, like Ali did. He saved Coriolis. I'm pretty sure you can save millions. Thank you so much for giving this opportunity. These are 2 books we have just launched yesterday. I'm pretty sure they are available in the reception desk. If you read them, I'm pretty sure you can detect many more critical ill patients and save millions of lives. Thank you so much.
Thank you, Kanaka. Have a seat for the question and Q&A session. We have some time for questions from the audience.
This question goes to Dr. Channa Jayasekara. In a patient with ACLF, the INR is about 2.5 or 3, and what is the place of giving FFP, or do we have to treat for the high INR or leave as it is?
That's a really good question. As I alluded to in the talk, the INR is a very inaccurate measure of coagulopathy in liver disease. There's been many publications on that. However, it remains the most convenient one that we use. The use of FFP is strongly discouraged currently. It will treat the number, but it would not treat the underlying coagulation abnormalities in cirrhosis. So the preferred measure of coagulopathy, if there's someone who is actively bleeding, is to use a thromboelastogram or TEG. And then you can also use fibrinogen as a measure of liver synthetic dysfunction. In patients who have a prolonged INR, it's not harmful to give them IV vitamin K to correct a nutritional component. I don't think there's a downside to that. But giving fresh frozen plasma is both from a volume standpoint, cost and efficacy standpoint, not really recommended, even in the situation of acute bleeding.
Thank you very much.
Yeah, one last question.
Next question is also from Channa. What is your idea of bowel sterilization? We give rifaximin. What are your thoughts?
I think rifaximin is an amazing medication. You are fortunate here to have rifaximin available very easily in the US. It's very expensive. It's about $3,000 a year because it is held by a monopoly. But in patients who have chronic encephalopathy, it used to be known as a second-line agent after lactulose. But recent data have shown that it can be used even as a first-line agent to sterilize the bowels. So I think it's very effective, very safe, and very well tolerated.
Okay, thank you. I think rifaximin is not that expensive in Sri Lanka. We are fortunate in that. We listened to 3 excellent speeches, but unfortunately we don't have much time for a longer discussion. And I thank all 3 speakers for your time and your excellent speeches. So with that, we will wind up. I'll invite my co-chair, Dr. Arosha Bekrama, to hand over the certificates of appreciation. First to Dr. Channa Jayasekara. Then to Dr. Upul Wickramarachchi. And to Dr. Ganaka Senaratne.